So indirect pulp capping. So by definition, according to as given in the Ingalls 5th edition, by definition, indirect pulp capping is defined as a procedure wherein small amount of carious dentine is retained in deep areas of cavity to avoid exposure of pulp, followed by, so what we are doing, small amount of carious dentine is retained. We are keeping, or we are not removing the entire carious dentine. We are retaining small amount of carious dentine in deep areas of cavity to avoid the exposure of pulp, because we do not want the pulp to be exposed, followed by placement of a suitable medicament and restorative material that seals off the carious dentine and encourages pulpal recovery. So that basically is indirect pulp capping. That means a caries that is deep, and then you are just removing the carious lesion, you're going on removing it, and at one point you feel that if I remove any more of the carious lesion, I am going to expose the pulp, and that you do not want to do. So you just retain, or you just leave behind a small part of the carious dentine so that you avoid exposure of the pulp, and you seal off that carious dentine. That means you use such a material that it seal off the carious part of the dentine, it will arrest the microbial activity there, and hence it will promote the pulpal recovery. Okay, now what are the objectives of IPC or indirect pulp capping? So the objectives are arresting the carious procedure. First thing is arresting the active carious lesion. Then promoting dentine sclerosis. Okay, then stimulating formation of tertiary dentine. And then remineralization of carious dentine. Okay, so we want to do by doing the IPC or indirect pulp capping is that we want to arrest the carious procedure, we want to arrest the active microbial activity going on in the caries, we want to promote dentine sclerosis, that means hardening of the dentine, we want to promote that, we want to stimulate the formation of tertiary dentine. Okay, that means we just read about the tertiary dentine, and then we want to remineralize the carious dentine. Okay, so these are the objectives of the IPC or indirect pulp capping. Now what are the indications of indirect pulp capping? So when we talk about the indications of IPC, so when we look at the history, there is mild discomfort from chemical and thermal stimuli. Okay, like for example, the patient might give a history of, when I eat anything sweet or anything what you call as hot, whenever I eat it, I feel a little uncomfortable. I feel like there is a little pain, or there is a sensitivity that is in this particular tooth, but which does not bother me. Okay, the patient is not bothered by that particular feeling of discomfort, but he can very well mention it or differentiate that there is something different. Then there is absence of spontaneous pain. So when, and there is the pain, a patient does not complain of pain, but he complains of a discomfort. So discomfort on consuming sweet or hot or cold food. And then absence of pain, there is absence of pain. Okay, then when we look at the tooth clinically, what we see a large carious lesion, there is large carious lesion present there. There is absence of lymphadenopathy. That means the lymph nodes that you palpate are non-tender and non-palpable. So absence of lymphadenopathy. There is absence of lymphadenopathy. Then normal appearance of the adjacent gingiva. The gingiva adjacent to that particular tooth is non-inflamed, non-erythematic. So the gingiva there is completely normal. So normal associated gingiva. Then there is normal color of the tooth. The tooth does not appear to be discolored. Okay, so these are the clinical examination. These are the points that we observed during clinical examination. Now, when we look at the radiograph of this particular tooth, again we will see a large carious lesion in the radiograph, which is large caries close to pulp. Because now in the what do you call as the radiograph, you can very well appreciate its proximity or distance from the pulp. So large carious lesion close to pulp. Okay, there is normal lamina dura. I am going to show you in the picture what is lamina dura. Then the normal periodontal ligament space is present. Normal PDL space. And then no interradicular or periapical radiolucency. No interradicular or periapical radiolucency. Okay, so these are the indications, or this is what we basically come across when we decide that this particular patient is to be treated with a indirect pulp capping. So this is the patient's history, what patient conveys. This is the clinical examination. And this is what is seen on the radiograph. Okay, so this is what basically happens in case of an IPC. Now let me just tell you what is the meaning of lamina dura, why is it normal in case of such cases, and what is the meaning of a normal periodontal ligament space. Okay, so just pay attention over here. So I'll have to draw the tooth again. Okay, so this is the tooth and this is the bone in which it is sitting. Sorry for a very bad bone in some place, but I'll have to remove it anyways. So now what happens, as you know, that there is something called as the periodontium or the periodontal ligaments present over that, links or bonds the tooth with the bone, or which attaches the tooth with the alveolar bone. So for example, these are the periodontal ligaments. Okay, so these are the periodontal ligaments. So what happens? The periodontal ligament on one end is attached to the tooth root, and on the other end it is lodged into the alveolar bone. Okay, now what happens? This particular part where the periodontal ligaments are lodged. Okay, so yeah. So this particular part where the periodontal ligament fibers are lodged into the alveolar bone, the one that I have marked in the yellow color, is called as the lamina dura, and the lamina dura appears as a single line that is radio opaque on the radiograph. It looks like that. So when you look at a radiograph of a healthy tooth, you will see that you are going to see there is this root, then there is a radiolucent space, and then after the radiolucent space you will find a dark radio opaque line over here. Okay, so just adjacent to the tooth root is a radiolucent structure, and then to the radiolucent structure just next to it is a dark line that is dark radio opaque, and that's called as the lamina dura. So this here is the lamina dura. So lamina dura are the nothing but PDL fibers lodged in alveolar bone. And then this is the lamina dura, and then this particular space where you can see the PDL fibers is called as the PDL space. Okay, so is it clear what is the lamina dura and what is the PDL space? So this is the PDL space, and just next to the PDL space is the lamina dura. Now what happens that this pulp, this here is the pulp. Okay, so whenever there are caries that have reached the pulp, the pulp becomes infected, and because of that infection, the infection through the roots reaches the periapical, area. So whenever the infection reaches the periapical area, what happens? It destroys these periodontal ligament fibers. So when it destroys the periodontal ligament fibers, obviously this space here also gets destroyed. So this entire space gets destroyed whenever there is a periapical infection, because if the PDL fibers are destroyed, so will the lamina dura be destroyed, because what is lamina dura? Lamina dura is nothing but the PDL fibers only. So the lamina dura will not be visible. So in case of a periapical infection, so just don't get confused, in case of a periapical infection, we can write that there is loss of lamina dura, because obviously what has happened, there is a lot of PDL fibers have been destroyed, because of which the lamina dura is not visible on the radiograph now. So whenever there is a periapical infection, periapical as in the around the apex area, that's called as the periapical. So whenever there is a periapical infection, there will be loss of lamina dura and widening of the PDL space. So there will be a little loss of attachment, there will be loss of the attached alveolar bone and loss of lamina dura. So the PDL space, because of loss of lamina dura, will appear to have been widened. Okay, this particular space this particular space here, the space where the PDL space, as I told you here in the diagram. So the PDL space looks widened because of the loss of lamina dura. So these are the statements that we write, that there is loss of lamina dura and widening of PDL space in case of a periapical infection. Okay, but when we are talking about indirect pulp capping, there the caries have not reached the pulp. They are about to reach the pulp. They are close to the pulp. Like I told you here in the radiographic examination, there are large caries that are close to pulp. They have not reached the pulp, so there is no pulpal infection, and if there is no pulpal infection, there is no periapical infection, and hence the lamina dura appears to be normal in a radiograph and the PDL fibers appear to be normal in the radiograph. This scenario occurs in case of a periapical infection. I hope I am very clear here that what do you mean. So these are the basically indications of the indirect pulp capping. Is it clear? Now, what are the contraindications? Exactly the opposite. So, when in case of contraindications, please just listen carefully. When we talk about the contraindications, that means where we are supposed to not do an indirect pulp capping. So, where when we talk about the history, that if there is a sharp shooting pain that persists even when the stimulus is removed, there it is contraindicated. So in indications what we had read, there is just a minor discomfort and there is absence of pain. So wherever there is an extreme pain or prolonged pain, that means you are not supposed to do an indirect pulp capping. Then on clinical examination, if there is excessive tooth mobility, there is pus coming in or around of tooth, and then there is discoloration of tooth or non-responsive pulp on pulp testing, then you cannot do an indirect pulp capping, because all of those things will show that there is pulpal necrosis or pulpal damage at least that has happened. So when the pulp is already damaged, you cannot do an indirect pulp capping because there is no normal pulp to be capped. In indirect pulp capping, you cap a pulp that is normal, but if there are signs of pulpal damage or pulpal infection, you do not cap the pulp because it is not normal inside. Then when we see in a radiograph, we see a large carious exposure that has reached the pulp, that has touched the pulp, and then there is broken lamina dura, there is a widened PDL space, and then there is radiolucency around the apex of the tooth that shows, or at the furcation area. So we have various canals and channels over here also. So an infection can occur in the furcation area or in the periapical area. So if that is visible in the radiograph, that means no point of doing a indirect pulp capping. So I hope I'm clear with the indications and contraindications of IPC. All you need to understand is there has to be normal healthy pulp inside in order to cap it and keep it healthy or protected. If there are signs of an infected or damaged pulp, that means you cannot do an indirect pulp capping. Okay. Now, what are the layers of carious dentine? So there are various layers of carious dentine. Okay, so when we talk about the layers of carious dentine, just look at the picture. So this is the caries. Okay, and this is the, say, pulp. So this is the pulp and these are the caries. Okay, now this here is the dentine. So as you can see in the picture, the caries are well within the dentine. So now what will happen? This is the bacteria. Okay, then we have an outer carious dentine and inner carious dentine. Okay, so like for example, if this is the carious dentine, this is the carious dentine. So we have an outer carious dentine and an inner carious dentine. Okay, so in the inner carious dentine, we have two layers, that is a turbid layer and a transparent layer. Okay, so let's just understand it this way, that in the inner carious dentine, we have two layers, this one and this one. So this is called as the turbid layer and this is called as the transparent layer. So turbid layer and a transparent layer together make the inner carious dentine. So this forms an inner carious dentine. And then we have a layer of obviously a reparative dentine that is close to the pulp. So these basically are the layers of the carious dentine. So we have in the layers of carious dentine, we have a so we have layer of bacteria that is in the core of the caries. Then we have an outer carious dentine and then we have an inner carious dentine that is made out of a turbid layer. Okay, I've written turbin, it is turbid layer. Yeah, so it is, there is a turbid layer and then there is a transparent layer which both form the inner part of the carious dentine, and then just pulp we will have a reparative dentine that has formed in response to the injury caused by the carious dentine. Clear? Now the outer layer is the layer that is necrosed, it is soft and brown dentine. The middle layer is a firm discolored dentine and the deepest layer that is present in is a hard discolored dentine. Okay, so basically these are the layers of carious dentine. So what you basically do when you do an IPC, so there is this tooth. So there is this tooth where you say this is the carious lesion and the pulp starts from here. This is the dentine, for example. This is the carious lesion. Okay, so this is the carious lesion and the center part is the pulp. So what you do, you take an aerator and then you remove the caries. Okay, so you remove the caries, you feel that if I go any deeper, then I am going to damage the pulp. So you just remove it here entirely, but you keep this much part of the dentine over there, the carious part over here only. Okay, now what you do, okay, so you've just taken an erotor and removed all the caries, but you've just left a small part. Just say it is a little more deeper or closer to the pulp. So you've left this much part of the pulp of the carious dentine that you think will result in pulpal exposure if you remove that much part also. So you've drilled a cavity, left a part of the carious dentine there. Then you take a material such as calcium hydroxide in order to cap the pulp. So you've taken calcium hydroxide and you've placed it over the remaining carious dentine. So you took calcium hydroxide and placed it over here. Okay, then you took zinc oxide eugenol to place it above it. So you took zinc oxide eugenol in order to build the strength and place it above the calcium hydroxide. And then later what you did, you took, a restorative material such as GIC or composite or what you call as amalgam, and then you build the remaining tooth structure. So this, dear students, is what you do in an indirect pulp capping. So you have a pulp here about which you are scared that it is very, very close to the caries is very, very close to the pulp. So what you do, you just leave the caries remaining caries, you just leave it there, and then you place an agent that is going to calcium hydroxide, and this is an agent that is going to arrest the microbial activity and try to remineralize that particular part of the dentine. Then you place a temporary material such as zinc oxide eugenol, and then over the zinc oxide eugenol you place a permanent restorative material, permanent restoration such as an amalgam or resin composite or whatever. So this is what you basically do in the indirect pulp capping. Okay, so I hope indirect pulp capping procedure is clear to you.